Hello and welcome to episode 2 of the Type 2 Diabetes Myth Busters series. I'm Dr. John Anderson. I practice internal medicine and diabetes at the Frisk Clinic in Nashville, Tennessee. We have two experts joining us today, Davida Kruger and Casey Wells. I'm going to let them both introduce themselves. Davida, I'll let you go first.
Hi, I'm Davida Kruger. I'm a certified nurse practitioner at Henry Ford Health in Detroit, Michigan, working in the Division of Endocrinology, Diabetes, and Bone and Mineral Disorders. I'm thrilled to be here tonight.
Casey.
Yep, I'm Casey Wells. I'm a clinical pharmacist practitioner and diabetes educator in Asheville, North Carolina, and I spend my time 50% in primary care, 50% in endocrinology. Also happy to be here, John.
Great, thanks for being here. So today we're going to tackle a really common misconception, like who is and who isn't a candidate for automated insulin delivery, or AID, in type 2 diabetes. We'll focus on why universal screening matters, how CGM data can uncover the right patients, and the real-world implications of integrating CGM with AID systems. To ground this in practice, we're going to get started with a theoretical short patient case featuring our patient, Mrs. A. So Mrs. A is 62 years old. She's had type 2 diabetes for 14 years, so she's pretty long in her journey with type 2 diabetes. She's on insulin therapy and a basal bolus regimen for the last 3 years. You can see that her CGM data shows that her time in range is only 45%, well below that 70% we like to see recommended by the American Diabetes Association. And we can also see when we look at her pattern, she has postprandial glucose excursions to 240 to 300 milligrams per deciliter, accompanied as well by occasional nocturnal lows. And you can see her A1C still pretty far away from goal with an A1C of 8.2%. Now, if you have an honest conversation with Mrs. A, she says, and she's honest, I frequently miss boluses. She has a lot of glycemic variability, we know, and you can comment on this, how that makes patients feel when they're up and down quite a bit. And she has this fear of hypoglycemia, even though she has a CGM, and she's really, and we see this so often, and I'd love to hear you comment about this later. I mean, she reports her burnout with this complex regimens. 14 years of diabetes, 3 years of basal bolus. I mean, this is a really human emotion for her about how this is impacting her life. And so, Davida, I'll start with you. In light of the 2026 ADA standards, how and why should clinicians screen people like Mrs. A for AID candidacy? Why should clinicians adopt universal screening for AID candidacy in people with type 2 diabetes on insulin?
Well, first of all, let's go over the new standards, and I was just thrilled. Casey and I have both done extensive research in type 2 diabetes using AID systems, and two of the systems have been approved for use in type 2 diabetes. The third one's right behind, and publications to support that. And of course, when you have the data to support, that's when the changes come. So AID systems are the preferred insulin delivery method over MDI, CSII, and sensor augmented pumps in people with type 1, adults with type 2, children and adolescents with type 2, and those with other forms of insulin deficient diabetes. And then choices of an AID system should be based on the individual circumstances, preferences, and needs. That means a decision to choose whichever they're going to choose should be made jointly. So one of the things I always think in my mind, and I'm thrilled that the standards of care are where they are and where they should be, is we're delivering insulin, and a pump is a method or a way to deliver insulin. And it actually makes, as you presented, burnout, it helps with burnout. It makes the delivery, we don't miss injections when we're on an insulin pump. The AID systems correct blood sugars when they're too high, and it pauses the insulin when blood glucoses are going too low. And, hypoglycemia is one of those rate limiting things to getting somebody to treatment goal. So thrilled that the standards have been there. So what should we do with looking at all of these individuals? Well, we also know that CGM should be given to all people at diagnosis. Certainly when you start insulin, both type 1 and type 2, that was a big change in 2024. So if we look at individuals who have type 2 diabetes, their journey to getting to treatment goal is not that different than somebody that has type 1. And if we're going to get them there, we have to prevent hypoglycemia. We have to prevent the roller coaster. We have to help them. And instead of 4 or 5 injections a day, why are we not using an insulin pump? And as I said, the research is there to support that those individuals with type 2 diabetes, and they don't have to be savvy with technology. Insulin pumps are very easy to understand, very easy to use. And so all people who are starting on insulin, we should be considered. And in the clinical research, those people that were on just basal insulin, we moved them to an insulin pump because it was time for them to get mealtime insulin. And the other thing we saw in clinical research is that you think, oh, well, we have SGLT2 inhibitors, we have GLP-1s, do we really need insulin? Yes, we really need insulin. And yes, we need mealtime insulin. And again, the clinical research showed that those individuals that were on a GLP-1, their A1C lowering was just as good as those people who were not using a GLP-1 that entered the study. So thrilled about the standards of care. Now we have to be screening those individuals, treat them with respect in terms of they're on insulin. This is a way to manage their diabetes better and offer them an insulin pump.
I think that's great. And I think we were all thrilled, Davida and Casey, about the getting rid of some of those restrictive guidelines that came out in 2026. And as you said, Davida, making this more broadly available to all people with diabetes. So Casey, what clinical cues, should prompt AID consideration in people like Mrs. A, or for that matter, anybody who has type 2 diabetes?
Yeah, so first with Miss A, she's insulin requiring. Another factor that makes her a good candidate, she's not meeting her goals with that current therapy. So those sugars were 200s, 300s from those missed meal boluses you were talking about, as well as the treatment burden, diabetes distress associated with those. And the AID systems really help alleviate that, as Davida was mentioning, by providing those auto adjustments to her insulin when the sugar goes high, helps give her a little bit more, maybe for that missed injection that she had. Yeah. But the patient, Miss A, she also had a fear of low blood sugars, and these systems will provide that added layer of protection by suspending the insulin delivery before she reaches that point. And another good cue for me is, though it's not required, is that she was wearing a CGM already before we would recommend an AID system that at least shows she has some comfort or familiarity with technology, but again, not a requirement at all for starting on it.
I would also add that they don't have to be carb counting anymore. That used to be a huge thing in insulin pumps, but we know that these pumps work well with individuals who can't master carb counting. And even those people that say they can, I'm not sure they're doing a great job.
Okay, so Casey, I'll go back to you. You've got a patient like Mrs. A. Once you've identified a patient as a potential AID candidate, how does CGM integration guide your next steps? What's the next series of things you think about?
Yeah, I have patients completely tech naive, like Davida was talking about, starting AID, but if they are on a CGM, that can help navigate which steps we go to next. And so I usually like to start thinking about cell phone compatibility for CGMs, because most AID systems, you can only connect one medical device to that pump and CGM. So those are usually the two that are talking to each other, which means patients cannot use a reader or receiver usually when they are using their CGM. So for example, on the slide, you can see if a patient is using that Dexcom G7, maybe with a reader because they don't have a smartphone or their cell phone's not compatible, they could still use an AID system like the Tandem T-Slim and start that Dexcom G7 from the pump itself. Or the patient could be changed to a different sensor system like the Freestyle Libre 2 Plus, and you're able to start that directly from an Omnipod controller. So not having access to a smartphone, that barrier is removed by both of those products being able to be used with the devices directly. And then the third one on the slide, the Medtronic or the 780G, it is approved for type 2 diabetes, but that one is cell phone compatible, only CGMs. And then once you figured out all of that, in general, many of the pumps for type 2 have shared compatibilities. So at that point, it becomes, to me, customization of the AID based on which algorithm I think is going to meet the patient's needs and match their lifestyle. And then it will wind down to the provider prescribing that kit that they think will fit best.
Okay. So, Davida, making AID evaluation standard for all eligible patients, what you're looking at the future, how's that transforming care?
Well, I think it's another opportunity to have a better outcome. Standard of care tell us that the oral and injective medications that all people with type 2 diabetes have, but we also know they're going to need insulin at some time in their career of diabetes. And saying that people who have type 2 diabetes should also be wearing an insulin pump and having that conversation when you're thinking about prescribing insulin. So not looking at the patient and saying, oh, your A1C is too high, because you hear all the time that a patient's A1C is too high. They must not be taking their insulin, so they're non-compliant. Well, they may be non-compliant because you threw 4 injections of insulin at them, from the get-go. But if you pull back, give them an insulin pump, then the insulin flows and they don't have to think about it. So, looking at that and not making an A1C or the patients at treatment goal. Here's the thing about the patient at treatment goal. They work so hard every single day when they're on MDI to avoid hypoglycemia, to avoid hyperglycemia, to get every one of those injections. So what this does, the screening does, by making us look at all individuals, is that we're not making the A1C the get-go or the end-all, be-all to determining the A1C. The other things that the American Diabetes Association said, C-peptide, let's not look at that anymore. So in type 2 diabetes, we've always had to look at C-peptide. And if the patient was making any insulin, trust me, it wasn't enough to keep them out of needing injections. They could have been on 4 injections and still made a smidgen of insulin, but it was too much to get an insulin pump. Now we're saying that's not an issue at all. If they have complications, it's not an issue. If their technology is not great, everybody, you're thinking about insulin, you should be thinking about offering that individual an insulin pump. And so I think that's the things that are going to go by the wayside, and not that type 1 and type 2 diabetes are the same disease, but when you get to insulin, the way we should be offering care and the technology should be the same.
And Casey, you've had those patients, right? The patients who are well controlled, but they want a better system. But also, to Davida's point, the patient who may have an A1C at 12 or 13, and you introduce them to an AID system. You've seen the success.
Yeah, I think mentioning it early on as a standard of care really just helps normalize it with patients, just like we had to do with CGMs. So saying to my patients, I think you would be a really great candidate for an AID system based on these newest guidelines. And I'm going to keep offering them to you as a provider or educator because it's my job to make sure you have the best access to care and the best outcomes. And so that's typically how I phrase it when I continue to offer it to people.
I think that's the same thing we do in practice. I had a patient today who finally, after years of sort of keeping his type 1 at bay and not checking glucose was fine by the seat of his pants, he said, I really want to try going on a pump, matching it with my sensor, and we're going to hook him up. So again, I think it's kind of like smoking cessation. Just keep knocking at the door, right?
Yeah, I think too, when you look at how insulin works, and you're taking 4 injections a day, the roller coaster that the patient tends to be on in the best, in the best care. And so giving a pump, and so often the patient says to me, why didn't you make me do this sooner? I'm like, well, like Casey said, we've been talking about this for a really long time. But I think moving the request or the conversation to the beginning of the diabetes, to the beginning of the insulin. And as Casey just said, making sure you go back and say, are you ready now? Or let me show you. And making sure the patient understands what it is and what it isn't, so that they're not afraid of the technology is important as well. And the clinicians. Sometimes I think the clinician's more afraid of going to a pump than the patient.
And I think that's really the issue for primary care, who take care of a lot of the patients with type 2 diabetes, that this technology is not to be feared, but to be embraced, right?
Yes.
Okay, well, Davida, Casey, thank you for this great discussion and all the valuable insights you share with us today. We also want to thank you, the audience, for joining us. Please be sure to come back next month for the next episode. Also, please be sure to scan the QR code you see here to claim credit for attending this program, and visit the link to access additional CME programs and resources for the use of AID systems in type 2 diabetes. So once again, thank you for being with us today.